Ladies and gentlemen, please visit All India Radio Facebook page and like it. Here we bring you news, information, calendar of events and interesting stories from around the world, round the clock. So please visit All India Radio Houston page on Facebook and like it. Thank you. Ladies and gentlemen, all our talk shows are catalogued on YouTube under the blog All India Radio Houston. So please visit YouTube and look for our blog All India Radio Houston. There you can watch the previous interviews and other interesting clips. We have more than 300 videos covering various aspects of Indian experience here in Houston and from around the world. So please visit YouTube and subscribe to All India Radio Houston page so we can keep you updated as to the latest additions to our video blog. Good morning, ladies and gentlemen. I am Dr. Nik Nikam. You are listening to 1050 KCH in Houston, Texas. Foundation for India Studies brings India Bee 2015, which is going to be held on March 29th, 2015 at India House. This is geared towards students in the 6th, 7th, and 8th grades. It's going to run from 9 a.m. till 6 p.m. So if you have any if you'd like to get involved, please contact Krishna Wabilala at 713-795-5169. We are talking about St. Luke's Hospital, and my special guest is Rob Heifner, and he's the Chief Executive Officer of CHI St. Luke's Hospital. We are going to switch gears and talk about our personal perception of future of medicine. So this is in no way reflection of All India Radio Houston or that of CHI St. Luke's. It is just our personal views as to what we think it is. And Bob, I'll let you go first. Rob.
Well, that's a question that probably could fill many hours of a program.
Yeah.
And so my perspective comes obviously from administering a hospital, but I work with physicians every day. So I rely on physicians. Without physicians, I have no reason to exist. And so I have to look at it from the perspective of the physicians as well. When you look at healthcare today, the days of Marcus Welby and the house calls and all of that, those are long past. There are over 5,000 hospitals in the United States right now. I think that probably in the next 10 to 15 years, that number will shrink greatly for the inpatient care.
What do you think is the main driving force for this shrinkage, which we are already seeing?
Well, I think what it is, I think number one, there are two things I think to answer that. Number one is we've got the most technologically advanced healthcare system in the United States. And so we enjoy a lot of benefits from that. But the history has been, from an economic perspective, is that you do more and you are paid more. Physicians, unfortunately, because of frivolous lawsuits and those things, have had to practice defensive medicine. And so when they do that, there are more tests and more things ordered. And that's to protect them and their practice and their lives. But the cost has really escalated. And so there's no question that we do have high-cost health care. So hospitals are going to have to reinvent themselves and diversify and start doing more outpatient procedures and things on the outside. The idea is going to be, as crazy as it sounds from a hospital administrator, is to keep people out of the hospital. That's what we're going to have to do, and look at population health. How do we keep populations more healthy? There's always going to be a need for hospitals. You're always going to have a need for inpatient beds. But how are we improving the health of the population to keep them out of the hospital and keep them healthier to begin with?
Okay, that's fascinating. You said you've been in healthcare for almost 20 years. Going back 20 years, now looking forwards 20 years and 20 years further down the line, what do you think is the biggest challenge in the healthcare industry from a provider perspective, from an administrative perspective?
From a provider perspective, I think the world is changing. I mean, I obviously employ nurses.
That's right.
I do employ some physicians, but I talk to physicians every day. Probably 40% of the time of a nurse or a physician is spent on something other than taking care of the patient. And their administrative
duties. Computers and
absolutely, and thanks because of all the governmental regulations and the requirements of payors and things like that, is that that shift is, I talk to physicians who are frustrated every day. I went to school to be a physician, and I spend almost half of my time doing something else and administering a practice and this, that, and the other. And I see that
in cardiology, it was more like 70% of the time, labor, effort, and resources spent in administering this.
Absolutely. And so what concerns me is the time actually spent with the patient. And I look at it from my nurse's perspective too. They have to see the patient, they have to assess the patient, then they have to do all of their work on the computer to get everything in. And so we try to make sure that we go above and beyond taking care of the patient at the time that they're at the bedside with the patient. But as we go further in the next 20 years, back to your question, is what is it going to look like? I don't have a crystal ball. I wish I did. But what I do see is physicians and institutions coming together to try to band together because we're all in this together.
When I did my master in healthcare administration about 3-4 years ago, I wrote a paper on healthcare delivery across the globe. Europe, like England, France, Germany, even Japan, Canada, all these countries have national healthcare system. And of course, Obama tried to establish a national healthcare system, and most of the people in other countries, Europe, Japan, and Canada, they are generally happy, and their cost of healthcare is a fraction of what we spend in this country. Do you think a national healthcare service is an alternative in this country, and the American people are ready to accept it?
Well, I don't think to the extreme that it could go, meaning like that the government is the only, the only insurance plan or anything like that. I think that is the extreme. Do I think that there needs to be some changes? Obviously, there need to be changes. I mean, you spoke about the other countries like, Europe or Canada or Asia, where you can look at life expectancy, and life expectancies in a lot of those countries are much higher. The cost of health care is much lower, but of course, this country was really founded on these personal freedoms, and a lot of this has to do with human behavior. And how are we going to change human behavior? And I think that is going to be a big key in this. Now, we do need to reduce the cost. An example of this is, I see it every day, and other hospitals do, is that the use of the emergency room as the primary provider for patients, that's the highest cost delivery location to be able to provide primary care. And so we need to redirect that back out into the outpatient setting and back into private practices. And you'll see hospitals trying to diversify themselves and actually building community emergency departments to take care of those patients who aren't going to be admitted to the hospital, but they can be taken care of and sent home. So there's a lot of things on the cost side that are going to be forced down our throat that we're going to have to deal with in the future. But back to your question, I see more and more physicians wanting to come together with institutions to try to solve this problem collectively.
Absolutely right, because as I said, the cost of running a medical practice is so astronomical, and with so many regulations. I'll just give you an example. About 5 years ago, when I used to see Medicare patients, you send a claim to Medicare, we got paid. Now we got all these Medicare HMOs. All those patients, for every visit, we have to have authorization.
Right.
If you don't have a referral from the doctor, we're not going to get paid. And more than 50% of their office visit is a copay. So they're putting extreme burden on people, physicians, and all these things, and it's going to make it impossible to sustain a private practice.
It is. There's some... some of the reasons for doing this, from either payers or from the government, a portion of this has some merit in trying to pay for value as opposed to trying to pay for quantity, if you will. And so value-based purchasing is a function of Medicare that is that hospitals have to live with. And it's going to go to the outpatient world, to the private practitioner as well. And the concept of that is this, is that right now the federal government withholds 1.5% of the Medicare revenue from hospitals.
Even doctors.
And doctors as well. And you get a rebate on that if you have taken care of a patient properly, if your outcomes are good, if your patient satisfaction is good, if you have used evidence-based protocols in taking care of patients for certain conditions, and if you do that effectively and you improve quality and you improve satisfaction, then they'll give you your money back. And I think, you can talk about what those incentives do and how they drive, but that's where the future is really going to be, and there's nothing that I individually can do about that except try to come together with physicians and provide the highest quality, the most efficient system that we can. I need to make it easy for physicians to practice in my facility. I need to make it easy for nurses to practice in the facility. I need to improve the quality and improve the patient satisfaction. That's the key. And unfortunately, with all of this government regulation, I think what gets lost is the actual patient.
That's right. You mentioned quality, and obviously, in order to show quality, you have to collect a lot of data.
Yes.
And a lot of physicians' offices are not geared or have the resources to collect all this information to provide to Medicare. I mean, everybody needs to be responsible, but the cost of showing that you're responsible, far exceeds what the benefit we are going to get, because all the time that's taken off your practice, it's a wasted resource.
Well, and you obviously know about an electronic health record, which is supposed to improve efficiencies across the board. And in theory, yes, that's true, but the devil is in the details, because at St. Luke's, we just implemented an electronic health record in the past year and a half, and the cost of that is between $75 million and $100 million just to implement a system.
Oh, yes.
And so it's enormous, and for the individual physician who might practice at 4 different hospitals that might have 4 different systems, theoretically, they're all going to be talking to each other at some point, but it's very frustrating for physicians as well. And you make a good point about the cost of the individual practitioner to have to implement that into their practice. It goes back to my point about how much of their time is spent practicing medicine versus administering a business.
Okay, let's talk about this Obamacare, the insurance particularly. Not getting into the politics here.
Right.
How does it affect the hospitals? Because some of these patients have a lot of restrictions.
Well, I'll give you a couple of statistics. So our charity care or uninsured patients that are coming in the hospital is around 10%. Okay? Probably means we probably offer anywhere from $18 to $20 million a year in charity care at St. Luke's Sugarland. And so you can do the math and see how that adds up. Theoretically, when you look at Obamacare and you look at the percentage of people in just the state of Texas, 25% of the people in the state of Texas do not have health insurance. Now, if you can get those people insured, at face value, that seems like a very good thing to do. To be able to have reimbursement for the providers, the physicians, the nurses, the facilities that are taking care of these patients. Here again, the devil is in the details. What is the question going to be? Is there ultimately going to be a mandate like you have with your car insurance? You have to have this insurance, or you're going to be paying a penalty. And it's really a burden on small businesses, is what we have seen. Is that you see a small business that may employ 10, 12, 15 people that now are going to have these mandates to be able to provide insurance to employees or else pay penalties. So the ideas of exchanges, that's nothing different than just private insurance. It's just a little bit different format. The question is that you can't get away from the politics of it. You want to, but you can't, because you've got lawsuits every day that are popping up, questioning the constitutionality of these mandates and those kinds of things.
Fascinating. We almost spent 30 minutes. I didn't even look at the clock. It's been a pleasure talking to you, and maybe we'll continue this discussion again. And my guest is Rob Heifner. He's the Chief Executive Officer of CHI St. Luke's Hospital. We're going to take a break.